Thank you for attending the National Consortium of Telehealth Resource Center webinar series for community health centers. My name is Kwong. I'm the Executive Director of the Center for Connected Health Policy, which is one of the 14 telehealth resource centers out there. There are 14 of them, 12 which are regional telehealth resource centers that service specific states. If you're interested in telehealth questions or how to start a telehealth program, they are a wonderful resource to reach out to. And then there are 2 national telehealth resource centers. CCHP is the one that focuses in on policy. There is another one that focuses in on technology based out of Alaska. We all work collaboratively together, so if you have questions on telehealth, I encourage you to reach out to one of us and we will try to help you as much as possible. One of the things that we do as the telehealth resource centers is that we put on webinars such as this one. This series is specifically directed at community health centers. A couple of housekeeping things that I would like to say today. Your phone or computer microphone has been muted. So for questions that you may have for our speakers today, please type them into the chat box that you will see on your screen. There will be time reserved for question and answer at the end of all the presentations. We also have a post-webinar survey that we would like each participant to fill out. And as noted earlier, this webinar is being recorded and the recording will be made available later as will all the PowerPoint presentations. We're very fortunate today for today's topic on substance use disorders and opioids to have 2 very experienced and great speakers with us. We have Dr. Marwan Haddad from the Community Health Center, Inc., and Dr. David Kwong from Bright Heart Health. So Dr. Haddad will be going first today. He is with the Center for Key Populations at Community Health Center, Inc., the largest federally qualified health center in Connecticut and one of the largest in New England. He received his Bachelor of Arts degree from Harvard University and his medical degree from McGill University. He completed his family medicine residency at the University of Toronto and obtained his Master's in Public Health from Johns Hopkins University. He is board certified in family medicine. He is certified by the American Academy of HIV Medicine as an HIV specialist. He is also the recipient of the 2011 Primary Care Leadership Award presented by the Connecticut Center for Primary Care and was named Physician Healthcare Hero of 2018 by the Harvard Business Journal. Dr. Haddad is an assistant clinical professor of family medicine at Quinnipiac University, and I hope I pronounced that right. Dr. Khan is the Chief Medical Officer of Bright Heart Health, a national telemedicine addiction treatment program. Dr. Khan has practiced addiction medicine, addiction psychiatry since completing his psychiatric residency and forensic psychiatric fellowship at the University of California, San Francisco. Dr. Khan teaches at UCSF as a clinical faculty member and is the current president of the California Society of Addiction Medicine and chairs the association's committee on opioids. Dr. Khan has testified before state and national legislatures to expand access to treatment for opioid use disorder. So I'm just going to go over very quickly some of the objectives that we hope will be accomplished with today's webinar. An overview of telehealth policies related to provisions of substance use disorder services, different types of models in providing the services through telehealth, and understanding of challenges and solutions to use the telehealth to treat SUD in a CHC setting. I'm going to go over a couple of policy issues just very quickly because I want to reserve most of the time for Dr. Khan and Dr. Haddad. Just very quickly, information that at least I provide today should be regarded as legal advice. It's just for informational purposes. I happen to show or mention a company. Please know neither I nor CCHP has any type of affiliation with such an organization. So in regards to community health centers and how they can use telehealth to provide services to treat substance use disorders, it's a little bit tricky, at least on the federal level when you're talking about Medicare. But I just want to highlight a few areas on the federal level where there may be some room for community health centers to consider using telehealth to provide services. One of them is the use of communication technology-based services. It's a set of codes that CMS approved for this year where an FQHC actually can provide services via telehealth. And one of them is something called the virtual check-in. It's a very quick check-in type of service that you have with a patient. It does not fall on the heels of a service that took place 7 days before, and it does not result in service 7 days afterwards. And it can be done over video or via phone. And it is exactly what it is, just a quick check-in with the patient to see how they're doing. So it might have some applications for when you use some type of substance use disorder type of service. It's not a lot of money involved. These are considered to be very triage type services, very quick services that don't take a lot of time. So CMS is not offering to reimburse a lot of money for it, but they are something that you might be able to use when you're talking about providing some service related to substance use disorders. The other one is the non-real-time example of that. Same concept, but it's taking place over a platform that is not taking place in real time, an asynchronous type of option here, or store and forward if you're in the telehealth field and use that terminology. So again, same type of service that's not taking place in real time, and just a quick check-in with your patient that does not result in the service, or is not a result of a service that took place. The other things to be aware of on the federal level that could impact community health centers and how they treat substance use disorder was the Support Act that was passed. And in there, it opened up the home to be a site for where a patient could receive services, co-occurring mental health services. However, the tricky part with this is that on the federal level where Medicare is concerned, community health centers like federally qualified health centers or rural health centers can't act as that distance site provider. So they can't actually be the specialist providing that services. But it does open this up for your patients who are perhaps your patients in those types of settings to actually receive some sort of mental health service at the home and not have to come into your clinic. So it's not quite exactly something that perhaps a community health center could get reimbursed for, but it is an option that's open to your patient. This flexibility, this sort of opening up in the policy has not kicked in yet. It'll kick in on the 1st, so next week it will actually start becoming effective. What's a little bit more interesting, and we may actually have some use to community health centers directly, is the prescribing of controlled substances. Right now, that is ruled by federal law. It's Ryan Payne Act, probably some of you have heard that term before, and has very narrow exceptions on how telehealth can be used to do that prescribing of controlled substances without having an in-person exam of the patient. And it's really difficult sometimes for providers to fit into those narrow categories. But one of the exceptions was to have a registry that the DEA created, where if a provider gets on there, it means that they probably have been properly vetted and that they're a good actor. So if they're on a registry, it's fine for them to prescribe. The problem was DEA never created that registry. However, last year Congress said, DEA, by end of 2019, you'll have final regulations for the registry. So the DEA is working on that now. I think they're going to take it up to the deadline. So probably we won't see like draft proposals, draft regulations until around that September, October time, because then they'll need a little bit of time to get public comments back and then hit the end of the year deadline to say like we actually did what we were directed by Congress to do. So that could also provide some flexibility for community health centers. Now, you're probably asking me, well, but Medicare doesn't allow us to do this. Why would we be interested? It's because even though Medicare may not allow community health centers to act as that distance site provider, that specialist providers, your state level policy may allow you to do that, and particularly in the Medicaid program. And on the state level, you do see a little bit more flexibility for community health centers, but it varies widely depending on what state you're in. So just to give you an idea, this is just a little bit of an overview of state legislation this year. And where I have the arrows pointing is where you see like a lot of that type of policy going into place at the state level as far as legislation. And that's creation of pilot projects where you see some substance use disorder pilots, and also regarding prescribing. They call it online prescribing in a lot of places, but it basically using telehealth, telemedicine to prescribe. So you're starting to see like legislation at the state level there because they recognize a problem and they want to address it as well. Medicaid, basically what a lot of them do is we reimburse for some type of live video, and it can be very narrow in their scope, from we just do it for telemental and behavioral health all the way to it doesn't matter what it is, we're going to reimburse for it. Store for remote patient monitoring, a little less popular, but there are some states with policies around that. Private payer laws are also out there related to telehealth, and again, they vary from being very general and non-obligatory on private plans, all the way to something that is like very mandated, where they say you shall do X, Y, and Z. So it kind of again varies widely from state to state. Where you're talking about federally qualified health centers and rural health centers, again, vary from state to state. There are some states that allow very explicitly in their Medicaid programs for FQHCs to serve as a distance site provider, such as Maryland Medicaid. But then you have somebody like Georgia that says is explicitly both originating site and distance site. They can act as both. And then you have explicit prohibitions, like in West Virginia, saying they cannot serve as distance site providers. You also have a lot of Medicaid programs that are kind of vague about it. I'm based in California, and at this point, California is a little vague about how FQHCs and RHCs can do a telehealth. Just for the California folks out there, they're fine acting as a distance site provider, but they haven't written that out explicitly. And specifically for California, now changed soon. They're working on policy on that. But for a lot of states, you have that. The other issue that you would have for some states is that it's unclear whether they'll allow a FQHC and RHC to charge the PPS rate for a telehealth delivery service and get reimbursed for that amount. Again, it's going to vary from Medicaid program. So you have to be aware of what the Medicaid program does say specifically. And I hate to say this, in a lot of cases, they may not be that specific. So to try to help you with that, CCHP does try to track the Medicaid policies related to telehealth for all 50 states in DC. That's a shot of our website. It's an interactive map. So if you're interested in a particular state, you can click on it to bring up the information. And then I'm going to stop there and turn it over to Dr. Haddad. Just to let folks know, Dr. Haddad was very generous with his time, but he does need to take off as soon as he is done with his presentation. So if you have some questions for him, please type them in the chat box and he'll try to answer a couple of questions before he has to leave us today. So Dr. Haddad?
Thank you so much, May. Good afternoon, everybody. I'm going to go ahead and share my screen. Good afternoon again. So today what I'm going to be sharing with you is our experience at Community Health Center Incorporated in terms of how we integrated our medication-assisted treatment into our FQHC using telehealth. And specifically, the telehealth that we used was Project Echo. So as May sort of said, we at Community Health Center, Inc. are one of the largest federally qualified health centers in the nation. We're in Connecticut. We have 14 health center sites throughout the state, and we serve around 100,000 patients per year. At CHC as well, we have the Weitzman Institute. This is our education and research arm of CHC, and really the Weitzman Institute works tirelessly to continue to improve primary care and its delivery to the medically underserved and special populations. And a lot of the innovations, especially our technological innovations, really live at the Weitzman Institute, including Project Echo. As May said, I'm the medical director of our Center for Key Populations, and this center is really the first center of its kind that is focused on key groups who have experienced health disparities secondary to stigma and discrimination. And so within those sort of categories of groups fall people who use drugs, the LGBT and transgender populations, and the homeless as well as other groups. And so under the purview of the center falls a lot of our programs that you see up there, including our HIV program, Hep C program, and the program we're going to be talking about today, which is our medication-assisted treatment and substance use disorder management. The center is not a standalone center. This is where sort of Project Echo comes into play. The center really sort of serves as a core group of experts within CHC who we ourselves do see patients at 2 or 3 of our health center sites, but then also serve as the resources and the trainers for all for our providers across all the sites across the state. So I know we're talking about telehealth here, and so I know you're probably thinking about how you could use telehealth to establish your MAP programs, implement it, scale it up. But I think whether you're going to be using telehealth or not, ultimately, you really have to start to think about a few things for your model of care. So there's a number of different models that are out there. The CHC model that we use, we do induction, stabilization, and maintenance, all done on site. Our MAT patients are booked in as any other primary care patient. So basically our providers are seeing a diabetic, then seeing the HIV individual, then they might see the individual with common cold, and they'll see their buprenorphine patient as well. And our MAT providers tend to also be the primary care providers for the patients. Other models are out there that you may have heard of, the hub and spoke model, which has actually been very successful in Vermont. There, the induction and stabilization occurs in expert hubs. And then once the patient is in maintenance, they get transferred to the organization and it continues there unless there's a relapse or complications, in which case they get sent back to the expert hub. Other centers have really set up where prescribers have set times or days that they will only see their MAT patients. Other models are they have a MAT clinic as well. It's co-located but separate from the primary care clinic. So patients who need to go to the MAT clinic go to the MAT clinic, but if they need primary care, they'll have to go to the primary care clinic. And of course, there's the telemedicine model, which Dr. Khan will be speaking to you about later in this webinar. The big thing that we've sort of realized is you really have to set the tone of your program's philosophy. And that might sort of take a cultural shift that needs to happen not only within your MAT team, but across the agency as well. And I think the two big things that we've emphasized over and over again and that we've learned that we need to emphasize is really the idea of treating addiction as a chronic disease, which it is, but treating it really in the same context as we would diabetes, for instance, or any other chronic disease, right? So the idea of a diabetic who comes in, who is maybe 70% adherent to his medication, who is not really, taking their meals on a regular basis and can't give up their 3 Snickers a day, we continue to work with them. We continue to try to keep them engaged in care, bring in nutrition, maximize the medications we can give them, get them into behavioral health. So similarly, that's what we would do with somebody who's struggling with addiction, who may have times of doing really well, and then times where they might relapse, sort of on and off. And so the idea is really engagement. And with that, right, and we do this perfectly in primary care. This is our bread and butter. But we've also been practicing harm reduction for a long time in primary care when it comes to all the other diseases, exactly as I had sort of mentioned. So we need to make that crossover of the harm reduction and the acceptance of harm reduction approach when it comes to addiction, because I think it just seems to be so much more layered and maybe sort of more nuanced. We bring a lot of baggage, right, when it comes to addiction ourselves, sort of to the table when we're sort of treating our patients who are struggling with substance use. And so I'm not going to go through all the principles of harm reduction, but just harm reduction just makes sense when it comes to approaching this. We need ultimately to make sure that we engage our patients in care and keep them engaged in care. And that's how we're going to actually improve not only their health, but also the health of our communities and prevent deaths, basically, at the end of the day. This is what we're ultimately trying to do. And so, with some of these principles, right, substance use has always been part of society, and we need to just accept the fact that it will always part of that. We cannot eliminate substance use completely from our societies. We need to really, truly respect the dignity of our patients and respect their choices that they're making. So we really need to look at sort of decreasing the harms that are happening to our patient. And by so doing, we're really balancing the costs and the benefits to both our individuals and society overall. And this is something that needs to be sort of taught and retaught and talked about and processed on an ongoing basis in these programs in your health centers. Similarly, when thinking about your models of care, most of our care has really gone towards team-based care, and interdisciplinary sort of team-based care, and addiction has also been sort of going down that route, and that's what we've done in our clinic. We followed the way that we deliver care to all primary care is this way. And so we all sit in interdisciplinary pods, which consist of medical providers, behavioral health providers, nursing, medical assistants, and for our MAT prescribers, if you will, we've got our MAT care coordinators that sit in there as well and are really been key to our programs. So what I'm presenting here to you is the common challenges that we've sort of seen with our program since we established our program in 2007. But we've also seen this in our work across the board in other health centers and across the nation. With programs that we've worked with as well in terms of them setting up their MAP programs and scaling it up. And so buy-in is key, and I think we all know this, right? We need administrative buy-in, we need financial buy-in, and we need clinical sort of buy-in. And so if you don't have your senior leadership in on this, I think it's going to be a fairly limited program or a program that's going to end up sort of failing. So you do need that sort of buy-in there. And you need clinical buy-in, right? If you don't have providers who are buying into this and getting their X waivered and prescribing, it's going to sort of be a very small program as well. And so you got to think about finding your champions and leading with your champions and ensuring that they sort of lead the charge, if you will, for the program at your organization. But there's also a good argument. I mean, there's an argument no matter what that we do need to be doing this. We are in a crisis in this country. People are dying every day from this. And so from the moral perspective, there's a moral reason why we should be offering the evidence-based care of providing MAT and engaging people into care. But there's also a financial piece here. I don't know what your payer mix looks like in your health centers, but for us, we are 70% give or take Medicaid, and with the ACA, with the Affordable Care Act, we've been able to sort of decrease our uninsured. And our MAP patients really come to our health center on average 2 to 3 visits a month, whether it's for medical or behavioral health. So you can imagine that that also brings in the revenue that can be then put back into the program. So there's a really good argument to be made from a financial standpoint if you need to be convincing your CFOs and your administration around that. There's also an issue that we've constantly heard about is we don't have the time or the support to do this. And so this is where, you know, the whole concept of team-based approach comes, and you really tend to empower the whole team to be able to deliver the treatment plan to the patients as a whole, right? And so it really works really well. I rely on my nurses, my behavioral health, to really sort of bring and round out the program that we sort of deliver to our patients. And the patients actually really connect with the whole team this way and really find that they've got a great support at our health center from them. But also as providers and as team members, we also feel very well supported. And I can talk a little bit more about how we do this, especially when it comes to cross coverage, and we use a voucher system that keeps sort of everybody in play and connected as well. There's always issues around polysubstance use and diversion. Of course, there's always this discomfort around this. And so we always also sort of teach around the fact that with polysubstance use, so sort of, again, I bring it back to diabetes. You know, we do have some diabetics who are only diabetic, right? But a lot of them suffer from comorbidities, which may be obesity and hypertension and hyperlipidemia. And so similarly, when somebody's coming in with an opioid use disorder, they may just have an opioid use disorder, and the treatment for MAT can work fairly well. But we also see that they might struggle with other comorbidities, such as alcohol use or cocaine use or benzo use, and definitely sort of high comorbid mental health disorders there. And so really need to sort of bring them in. We know that that medication-assisted treatment for opioid use disorder, like the buprenorphine, is specific to opioids, but then we need to sort of engage them and work on the other substances and their mental health as well. In terms of the diversion piece, you know, we do have to think about this, of course. There are risk mitigation strategies that you can put in place. And as long as those are in place, I think you'd be sort of, you know, set to go. And we have really good, extensive toxicology screenings that we do, both urine and saliva. You can sort of do medication counts and random counts and set and check for buprenorphine in the toxicology screening. So there's a lot of different ways that you can do to just ensure that diversion is just not happening. But the big piece that I really want to sort of talk about is, I guess, sort of maybe not necessarily the elephant in the room, but definitely something that is fairly big, right? Because most of our providers get very little training in addiction medicine during their education, as well as after when they get out into practice. And so this is where, when we were thinking about how do we scale this up, Project ECHO came into play for us. And so I'm hoping that most of you have heard about Project ECHO. But if not, I'll briefly sort of describe it. ECHO really is a delivery model of care that was the brainchild of Dr. Sanjeev Arora out of University of New Mexico, who showed that through the ECHO model, primary care providers treating hepatitis C had similar outcomes as the specialty clinic did in Albuquerque. So what does Project ECHO do? It really, in many ways, builds as communities of practice, either across your organization, across the state, or even across state lines. It connects primary care providers who join on a regular basis with a panel of expert multidisciplinary faculty. And what they do is these primary care providers present their cases, their patient cases, to everyone and receive input back from the faculty. And over time, the idea is that everybody's listening to these cases, they're learning, and they're growing and becoming experts in their own right. As part of this, we also offer a sort of didactic curriculum that supplements all this. This truly improves access to specialty care, and it creates this force multiplier where you can get lots of local providers providing care to their communities right then and there. It's very easy. You're all joining by Zoom. We use Zoom to sort of to connect with Project ECHO, right? So you can sort of do the Zoom-based on your video conferencing technology, whatever that is, on your laptop, on your smartphone. It's very easy to connect and it's very secure. And as I said, these are the cases. In general, we tend to get through 2 to 3 cases per ECHO session, and then we tend to have a sort of a didactic presentation that tends to be around 20 minutes, give or take. So this is what the curriculum may look like. We have a core basis of the curriculum, and then we sort of add additional brief didactics based on topical things that may come up, or things that sort of may have sort of been brought up by the participants saying that they would like a little bit more information on. And really, it creates an incredible learning dynamic. It makes sort of providers feel that they're not out there on their own. They really sort of get empowered with this. They get reinforced in terms of that. We sort of shake our heads at times. We sort of smile at our successes. We cry together on the tough cases. But it really creates a wonderful shared knowledge in order for this sort of to occur, and it really sort of shows that whatever you as a program are going to be struggling with, indeed I will tell you that other programs have struggled with this, and so sharing how people sort of address these challenges across the board really prevents people from reinventing the wheel in many ways. This is a survey study that we did that we've sent for hopefully for publication. We'll get it published. But we really looked at both medical prescribers as well as behavioral health providers who started ECHO and then joined ECHO for at least 6 months, and we did the follow-up surveys as well. And the surveys really looked at the skills section, so skills and confidence section in terms of how they rated themselves, their approaches to team-based care, as well as the attitudes in general towards delivering buprenorphine in primary care from that. As you can see, there was really a big movement, the statistical significant movement in the skills and confidence section of how confident they felt that their skills have improved over time in dealing with substance use disorders, particularly medication-assisted treatment. There was definitely an improvement in seeing confidence in their team for the team-based approach, and the attitudes, particularly with the medical providers, feeling that this is indeed an appropriate treatment to deliver in primary care as well, despite the fact that they felt it might have been more disruptive to some of the workflow, and it definitely improved their professional satisfaction. Lastly, I just want to sort of say that we started our ECHO in February of 2013. We do it monthly, so once a month for an hour and a half, and we have our providers join, take a half hour from their lunch, and then get blocked out for another hour. And so this is probably the biggest ask of your agencies and organizations if you're looking for ECHO. This is not so that you can start your own ECHO. There are ECHOs out there. I run 2 ECHOs, both for our agency, but also for other organizations in Connecticut and beyond throughout the nation. But there are also sort of other ECHOs you can join. And so the ask that would happen on your organization's standpoint would be for providers to be blocked out for that hour and a half to be able to sort of join the ECHO and feel that. But again, I think there's a great financial argument to be made. Yes, there might be a loss of revenue secondary for providers not seeing patients during that period of time, but it is only once a month. And by doing so and increasing your program and bringing in more patients in, as I said before, if you remember that these MAT patients come in fairly regularly to the health center, and they can generate a lot of revenue, which would offset this time as well. But as you can see here, in 2007, when we first started the program, we had maybe around 4 to 5 data waivered physicians at 2 or 3 of our sites. And as of now, so we embarked in 2013 on the MAT Echo, beginning of 2013. And as of 2019, now we have over 50 data waivered providers across the agency, at every agency, at every site. And we also have behavioral health at every site, both individual and group, that's supporting this program as well, all through joining this ECHO. And through this, we have started over 2,000 patients on buprenorphine at CHC since we've established ECHO. So thank you so much. I hope that was sort of helpful. Here's my email. You can send me emails as well regarding any questions you may have, but I can also sort of entertain and take any questions now, and I'll turn it over to May if there were any that came in.
And yes, there are some questions. Thank you, Dr. Haddad. So I know you are on a time crunch here, so we'll just go through these pretty quickly. The first one is, Dr. Haddad, are only providers from your organization allowed to participate in the Project ECHO activities?
No. So we're open to any health centers who want to do that, and I can always sort of forward who you can sort of speak to in order for you to be able to join our ECHO.
Great. Do you have pain specialists on your team?
So our ECHO is specifically medication-assisted treatment, although, as you know, we probably get a lot of questions around pain. We do have an ECHO for chronic pain as well. So we run another ECHO specifically on chronic pain, in which they sort of do talk about this. But definitely, as we sort of have entertained a lot of questions at health centers from across the nation, particularly in California and other places, where they do sort of do both pain and MAT together, we do get a lot of pain questions as well. But in terms of our pain specialists, they sit on a chronic pain panel, and we can always sort of refer those questions to that ECHO.
Any participation in the pods with your dental providers?
We have not had any dental providers join our ECHO pain. We definitely have a controlled substance policy across our agency, and so both dental and medical and behavioral health all sort of play a role within that. And so there is that discussion around limiting the amount of prescriptions that go out that are opioid sort of based, but we don't have any dental providers who've joined our ECHO.
There's just one more question. How are providers trained to manage SUD patients, especially with the time allocated for them to juggle with chronic conditions, and SUD would take up a lot of time? Do they have additional staff resources and work as a team to address SUD patients?
Absolutely. I mean, that's the time crunch that I was referring to and why we went to team-based care. And so basically, and I'll just give a typical example, when a new patient comes in, they get sort of screened through with our care coordinators, they get put into my schedule, I see them, assess them, start them in buprenorphine. They come in weekly. But they come in weekly seeing our nursing visits as we sort of assess them, and then we get them into behavioral health groups if that's part of the treatment plan, and the majority is part of that. And so then they continue to come see behavioral health and or nursing through this voucher system that we talk about. So that way they don't get their prescription if they don't come into the group, and so they don't for them to receive that voucher that releases that prescription, if that makes sense. And they will see me on a monthly basis. And then our care coordinator really coordinates all of that around. And so when we have team meetings, case discussion meetings, that we review all our patients around that, so that we all are on the same page all the time on our treatment plans for our patients.
Okay, great. It's not a question, it's just a comment to you. Thank you, Dr. Haddad. I participated in your ECHO a few years ago. It was how our whole practice learned.
Oh, that's great. That's great. Thank you for that. That always, getting that feedback is always wonderful to hear.
Oh, you got one more. As a participant in the Weitzman ECHO, I want to say this has been a great asset to our MAT clinic, and I highly recommend it.
Oh, again, more thank yous. Thank you so much.
All right, then. Thank you, Dr. Haddad, for doing this today. I know you have to take off now.
Thank you. I do apologize that I have to do it. Thank you.
Thank you for the time you were able to give us. We'll now move over to Dr. Khan there.
Hi, so thank you everybody for joining the webinar, and I'm Dr. David Khan. I'm a psychiatrist by training, and I wanted to talk about the actual practice of telemedicine for medication-assisted treatment. And so I work with a company called Bright Heart Health, and I'm talking a little bit about our experience, and this is not so much a pitch as it is to say what it is that you can sort of implement within your own practice. And again, this is going back to the basic definition of telemedicine. This telemedicine involves real-time interactive communication, audio and video, very similar to the platform that we're using today. In fact, Bright Heart Health uses the Zoom app as well when we communicate with patients. The goal behind telemedicine is to improve patient health. I agree completely with Dr. Haddad in that it's a force multiplier. I currently sit on the California State Opioid Safety Group, and so we're looking at state-level interventions on how to get people into treatment to reduce the risk of fatal overdose. And what's very clear is that the rural areas, the areas that are most rural, are the ones most affected by the opioid epidemic, meaning that they have the highest rates of prescriptions of opioids, as well as the highest rates of accidental as well as fatal overdose. So with telemedicine, this allows us to expand our reach. And notice I put in slides of the Uber and the Lyft app, because really that's kind of what telemedicine is, or at least how I conceptualize it. With telemedicine, the physician and the patient are, though I should say providers, not just physicians, and the patient are distantly located. And one of the things that we do is we actually have people located wherever they want to be. And the great thing about telemedicine is that oftentimes the background, I'm sitting in a classroom in a random college right now because I'm giving another talk after this, but you can do it just about anywhere so long as it's private and confidential. And with the equipment, everybody has the equipment. You basically need an internet-enabled device, whether it be a smartphone, a tablet, or a computer that can allow the platform to happen. So if we think about outcomes for telemedicine, particularly around all things, what we see is high treatment retention, meaning that people tend to stay with telemedicine, and it's somewhat higher than in-person care. I will say that the NIDA, the National Institutes of Drug Abuse, is going to look at this, and I'm happy to say that Bright Heart Health was selected in a treatment protocol, which they're going to do in looking at rural areas comparing in-person care with telemedicine. So NIDA is really going to look at this question very closely around MAT. It addresses the treatment gap. We don't have nearly enough providers. 1 in 10 patients who needs treatment, only 1 in 10 patients who needs treatment does receive treatment. And if we look at the outcomes, they're comparable to in-person care, meaning that one is not necessarily better or worse, but essentially we're getting identical treatment outcomes. And that's particularly true of opioid use disorder treatment. There have been studies looking at it, and they found that people really do know differently in person versus via tele. And the really fascinating thing about telemedicine is that patient satisfaction is as good or even better than in-person care. Because if you think about it, if somebody's trying to stop using opioids, we're seeing them 2-3 times a month, sometimes even more frequently than that. And that's a lot of trips to the clinic. Whereas with telemedicine, they can be wherever they want to be, so long as it's private and confidential, and they can connect right off the bat. Now, when it comes to the technology piece, you're looking for you need an internet-enabled device. What we know for many of our patients, particularly patients in federally qualified health centers, is they may have devices, but they may have an issue with the data plan. One of the things that is true is that the internet availability is only going to get better with time. Where we are right now is somewhat built out compared to like Asia or Europe, but it's just going to get better. And even if they have poor connectivity over, let's say, out there, there's many hotspots available, McDonald's, Starbucks, those type of things. And using encrypted technology, they can use a public hotspot and still have a HIPAA secured connection. most people have an internet-enabled device. Even for individuals who struggle with homelessness, I visited a number of homeless service centers, and I always ask the staff what percentage of them have an internet-enabled device, and more than 90% consistently have it. There's also federal programs to subsidize internet connectivity, and this is for people within 135 to 150% of the federal poverty level. They call them Obama phones, but this is actually a program started in the George W. Bush era. So if you have somebody who's struggling with connectivity, there are federal programs to either fully subsidize, either completely pay for or subsidize their connection. Now, there's different platforms. A critical one is, of course, that you need it to be HIPAA compliant. You need to have a business associate agreement, and people always ask about the Apple technology FaceTime. Well, technologically, it's got sufficient encryption, but Apple has not yet and probably never will sign a BAA agreement with anybody. And of course, bandwidth requirements vary. There are some platforms that require very large bandwidth. Some of them don't require very much bandwidth at all. And part of the reason that we pick Zoom is that it's a low bandwidth requirement in order to get high definition video. As a program, these are the states that we cover. We'll be sending out the slides afterwards, so you don't have to worry about this. The states in which we're personally busiest is California. You can see them up there: California, New Mexico, Tennessee, Georgia, so on and so forth. But the rest of the states are the ones that we could potentially serve patients. Now, with telemedicine, one of the things that we find that is helpful to build in is some type of a connection. And if you were to go to the Bright Heart Health website and click on the Contact Us button, if you were to click on that virtual clinic button, you would literally open up a Zoom screen and you'd have one of our care coordinators meeting with you on the spot. So it's literally like entering a clinic, and so you'll be met by somebody and they'll say, "Hi, how can I help you out?" So that's one of the things that we can do that reduces problems around check-in, showing up, trying to figure out what's going on with the person and why they're coming to see us. We do a lot of groups. So the program that I work with, think of it as a full service addiction treatment program, albeit without walls. We have outpatient programs. We have behavioral health. We have nurses, care coordinators, physicians, prescribers. And a lot of the stuff that we do is via group. And what it looks like is sort of like what I describe as the opening sequence of the Brady Bunch. You see a bunch of heads on the wall talking, but it turns out to work really well. We've also designed an app to track and coordinate care. So that's something that there's app-based technology is growing by leaps and bounds, and program your own app turns out to be actually not that hard to do. So what does it look like in practice? What do we really see? So what I'll do is present a couple of case studies to get your brain thinking about the ways that you can do things. Because what we're used to is we're used to having the clinic, people come in, and within that clinic, you know how the clinic works. When we started in New Mexico, well, for those of you who live in New Mexico, you recognize it's an incredibly rural state. Places are far away. And there's two major population centers, Santa Fe and Albuquerque. And what we have is both male and female patients of all ages, and more people access treatment and they reduce their driving. We have a standard, kind of a normal distribution, and the gender split is not that much. The really fascinating thing I find about New Mexico is we have intergenerational treatment. It takes one family member to access treatment, and when they have success, they tell their other family members about it too. So we have cases where we're treating grandparents, parents, patients. No, they're all patients. They just happen to be part of the same family. But it's, as we know, that addiction is transmitted through families. I think it's still true that 50% of people who first used heroin was introduced to it by a family member. The access to treatment allows for families to enter treatment at the same time. So telemedicine, and with New Mexico, we're dealing with mostly primary care programs and some people who are not attached. And our view is that primary care is a critical part of addiction care. And so people may come in seeking addiction treatment, but one of the things that we always put on the issue or the problem list is lack of access to primary care. And we make efforts to get people into primary care. If we look at the community hospital of the Monterey Peninsula, So one of the places that telemedicine allows us to do is we can connect networks. So Community Hospital in Monterey Peninsula is a small emergency department, and we went to the emergency department and we were able to implement interactions with the emergency department and get people into care. When we look at the results, we were able to implement very quickly. When I say very quickly, less than 30 days by training the ED staff, getting the wall posters, handouts, and brochures. We had more than 25 interventions and referrals in the first 60 days where patients would be started on buprenorphine in the emergency department, and then they would be handed off to us. And the remarkable thing is 100% of the patients made their first appointment, and 95% of the people were retained in treatment at 30 days, which was a significant improvement over the Yale study. And this very same thing was studied at Yale, where they found about 72% retention at the end of 30 days if somebody got started on the medication. So emergency departments is another place that we can interact. And if we look at primary care, so Dr. Haddad did an excellent job about the ECHO program, talking about building local capacity. And we actually interacted with Hill Physicians Group. They're a large IPA, independent practice management associations. We were able to implement within primary care very quickly. We trained the staff, we gave them wall posters, handouts, and brochures, and within 5 weeks we had 25 interventions. And it's worked out really well because one of the nice things about telemedicine, especially if you're digitally native, we do a lot of communication via secure messaging. So most EMRs, by law, at least certainly in California, and I think maybe nationwide, there's requirements to have secure messaging so you can talk between platforms. And the nice thing about secure messaging versus faxes is that the message will get there and can be instantly imported into the EMR rather than faxes that get lost. With Hill Physicians Group, we were looking at patients with more than 90 milligram morphine equivalents a day, and people had been on full agonists for more than 6 months. Now, what are the outcomes? So one of the things that I knew that was critically important was to look at outcomes. What happens when people enter care? And this is a bit of a busy slide. Hopefully you're looking at a big enough screen. We look at substance usage itself. So the primary measurement that we use is called the BAM, the Brief Addiction Monitor. And we showed that improvement in heavy alcohol use, use of illicit drugs, and any alcohol use. So if you look at the slides here, on the upper right-hand corner, these are the pre, and then on the right-hand is post. And so if you look at this very small print, alcohol consumption, binges, drug use, opioid use, sedative use, cocaine use, stimulant use, cannabis use, and inhalant use. And we've managed to lower just about everything in the patients that we've studied to date. The one that really remains sort of the sticking point is cannabis, which is probably a talk unto itself. And on the bottom right-hand side, this is a Kaplan-Meier curve, which shows the probability of improvement. And most of us think about improvements in substance use as being in the first 90 days. But what our data is showing is the longer you stay in treatment, the better you're going to do. So there's this linearity of improvement that just continues over time. One of the nice things about the BAM, the Brief Addiction Monitor, which was developed at the VA where I used to work, is that we look at protective factors, things like confidence in your abstinence, positive social support, work and school volunteering, income stability. And one of the other outcomes that we're finding is that across all domains, people are improving in their protective factors that reduces the risk of substance use. And again, on the bottom right-hand side, we see that people continue to improve over the course of time. And if we look at the reduction in risk factors, so these are things like cravings and withdrawal, negative social support, negative moods, physical health. What we're finding is we're seeing decreases in risk factors over the course of time. Again, with Kaplan-Meier curve, it takes time. The first 90 days is where we see the greatest amount of improvement, but over time, that improvement continues as you keep patients in treatment. When it comes to retention rates, if we look at 30-day retention rates, we see very high retention at 30 days at 81%. And at 90 days, we're looking at 56%. And that is for an opioid use disorder population I would consider pretty good, on par with that of in-person programs. And with sub-analyses, we're finding that patients who struggle with chronic pain are a specific group that we developed interventions around that I'll talk about at another time. If we look at the rates of drug screen positives, they're very low, both for opioids at 30 days as well as 90 days. So people are using less. It doesn't mean that they stop, but that's also part of the disorder itself. Even though people are still continuing to use, we're seeing improvements in other areas. So just in summary, I would say that telemedicine is accessible. Bright Heart Health is one solution, but not the only one. And I certainly encourage you to build your local solutions in which you can get experts quickly available. The rules are changing, as May talked about. Payment makes a difference. I didn't cover that slide. And we see that people do just about as well. My contact information is below, and I will stop my prepared talks and open up for questions now.
Okay, we've got several of them for you. I'm going to group a couple of these together, and this question should not be a surprise to you, Dr. Khan,
yes.
But about the Ryan-Haidt Act. Yes. So how do you get around that? How do you prescribe? Because there is that in-person element. There are some exceptions, but what do you do with the Ryan-Haidt Act and prescribing controlled substances?
Yeah, so we have providers located throughout, and what we do as a company is we rent ad hoc office space. Often, but the company that we use the most is called Regus, R-E-G-U-S, to meet with the patients. And historically, we started that way. Now what we're doing is we're actually putting the tablets into primary care, emergency departments, police stations, places where they can be seen in the presence of a DEA registrant, which is one of the exceptions that then establishes that relationship. And come October of this year, October 24th is the technical deadline, they'll populate that special registration category in the Ryan-Haidt Act, and hopefully we would be eligible for it. I actually testified for ASAM before Congress around that specific amendment that got into the Support Act. So there's a bunch of different ways to do it. And one of the things that I do know is that there's some people who do telemedicine without any type of in-person encounter. And though it's technically illegal against the Ryan-Haidt Act, the Drug Enforcement Agency has never prosecuted somebody for a violation of the Ryan-Haidt Act when they're working in the usual and customary practice of medicine. So we don't do that. We try to get people plugged in through in-person care, or we try to utilize the exceptions where they are at right now. But hopefully we'll be able to pick up steam when they've changed the laws.
We are not advocating that you do not follow the laws. That's just an example that Dr. Khan gave out there that he knows of.
Yes.
What some people, not Dr. Khan, are doing.
Right.
Dr. Khan, are you tying in with any of the bridge programs out of the ER in California?
Yeah, so I was one of the people on the work group with the ED Bridge program. For those of you not familiar with it, ED Bridge, ED-BRIDGE, was something started with the California Healthcare Foundation. And so we're collaborating with the bridge programs to help people to continue, because what we can do is we can tunnel into the emergency department, see them while they're in the midst of their buprenorphine induction to establish a relationship, and then continue working with them thereafter. And I think ED Bridge, where EDs start buprenorphine, this is a nationwide movement. It started in California, but I think it's going to be approved by the American College of Emergency Physicians as a stance.
This question may be related to that, but I'm not 100% sure, so I'll ask it. How is your program funded with your work with the ERs?
So our program is funded through typically fee-for-service reimbursement, and the work with the EDs, if we can bill for that, we can. If not, really the money is to be made in chronic care, just like with FQHCs. That initial assessment, the payment from Medicaid is not very good. And by the way, we strive to accept all forms of commercial as well as Medicaid in all the states that we're in. And we're in different places with different states because, as everybody knows, Medicaid is kind of Byzantine. But a lot of this, we try to do the next right thing. And with that, we can get patients in as we get them in from the emergency department.
The study at Monterey Peninsula, are you able to share the size of the study? It is promising to know that telemedicine is able to access patients who need help and support with SUD.
Yeah, I mean, this wasn't a study. This is our own quality improvement data. So we were looking at the data, and I think the CHOMP data is now up to, I think we've had over 60 patients at this point, maybe more. I can't remember, but if I look at my database, I could pull that immediately. But I can't share that right now, otherwise I'd be committing major HIPAA violations.
We don't want that to happen.
No.
Okay. Regarding group counseling, what has been the update in enrollment, i.e. what proportion of patients identified as candidates for group accept and attend?
So we make, part of the care delivery model is that groups are our modal form of physician service delivery. And I say the modal form because that's the only way we can get Medi-Cal, because we don't negotiate with Medicaid, it's Medi-Cal in California, to get differential rates. We accept the rate that they give. And in doing so, with groups, we can do group disease management, just like with diabetes or COPD, and it's very effective. Patients are always offered the option of group, but some of them decline. I would say the majority of patients we ask to give it a trial, and most of them like that. There's probably about 15 or 20% of patients who are either inappropriate for group or just plainly decline it. One of the nice things about telemedicine, especially if you're all over the state and maybe even in different states, is that people really feel anonymous within that group setting. They have their first name, last initial, and there's no way that they can be identified within their community, particularly small communities as well.
Can you talk about the functionality in your telehealth product in addition to the face-to-face with care manager and groups that you mentioned? So
I'm not sure what you mean by functionality, because we can do, for example, in Marin County, Dr. Jeff DeVito calls us the glue for the system because we're connecting EMS. So we do, one of the things I didn't talk about is we do EMS surveillance. So if there's any evidence of an overdose, we get a natural language voice transcript sent to us through a sharing agreement, a HIPAA compliant transmission. We actually make efforts to reach out to the people who have overdosed. We catch maybe 10 to 20% of people, but at the same time, we offer them treatment, and people are invariably grateful for somebody reaching out to them who cares. We can connect with the police station. We can connect with primary care. We can connect with the methadone clinic. And so that's, when I think about sort of functionality, yeah, we can do face-to-face with care managers as well as the groups.
There's a question about what's prescribed. Do the providers prescribe Vitrol or oral naltrexone or only buprenorphine?
So primarily we use buprenorphine. Obviously there may be adjunct medications like clonidine and other things during the induction process. When it comes to long-acting injectable naltrexone, we try to get people, we use frankly, the company's platform to get people connected with local providers. Since we don't have an on-the-ground presence, we can't easily give the injections. We're trying to partner with local pharmacies who'd be willing to do that, but the problem with long-acting injectable naltrexone is that it's an injection in the butt, and it's 3 cc's of fluid, and it's not easy to do. I do them within my private practice, but we're working on implementing it. The other thing I'll say about long-acting injectable naltrexone is the data for that versus buprenorphine is not as good. Don't be fooled by the Lee study because they talk about the study group, but if you look at the intent to treat analysis, 22% fewer patients are able to get on naltrexone versus buprenorphine. And if I use the My Family standard, if one of my kids developed the disease of addiction to opioids, what would I do? I tell them to get on buprenorphine because the outcomes are just as good as when people are on long-acting injectable naltrexone, but more people can get on buprenorphine.
My question is whether there are any self-management tools in the system, example, risk assessment, mood monitoring, remote monitoring, etc.
Yeah, that's one of the things you can do via Tele is that when people get used to a web platform or use the app, they can put all that stuff in there. So people get used to answering questionnaires, just like when they come into your FQHC and you hand them questionnaires to monitor their mood. So things like the Beck, we use, my mind is blanking on but we use the typical things like the audit, the BAM, the Socrates, various standardized depression and anxiety measures. And the nice thing about doing it digitally native is you can then put it into your database system and look at that. And a lot of our interventions are actually automated nowadays because of the BAM. When we identify people struggling, we can then recommend an intervention. The other thing we also do is we use artificial intelligence / machine learning to guide predicting the future. So one thing that we've learned is that if somebody comes in with a 4 on their pain score, we have to address that immediately. Otherwise, they're going to stick in care for perhaps 60 days. If somebody talks about not having structure in their life, they're not volunteering or working, that's also another predictor of when somebody's not going to do well.
Dr. Khan, we're almost at the hour. Do you have maybe about 5 more minutes? We have a couple more questions.
Sure.
Okay, so there's actually a group of questions around billing and reimbursement. So I'm going to take part of it first, and then I think, give you an opportunity to add anything. So I understand there may have been some issues with my mic at the beginning. So if you didn't hear, especially for community health centers, the billing, it's going to vary from state to state. Especially if you're talking about the Medicaid programs, because some Medicaid programs may explicitly prohibit a community health center from using telehealth to be that distance site provider and provide some of these specialty services. Other states are very explicit about allowing that. And then there are actually a good portion of states that are silent on the issue, so they may or may not. And then when you get into the commercial payer side, again, that's going to vary sometimes from payer to payer. So it's really going to depend on what state you're in and then what payer you're trying to access to get that reimbursement. So Dr. Khan, I don't know if you want to add anything with some of your experiences on payment?
I'm the chief medical officer. I'm not the chief billing officer, but what I know is that it is Byzantine. State to state, the rules are different. Plan to plan, they are different. But what I can tell you, having interacted with sort of the higher ups within the commercial health plans as well as Medi-Cal, they really see this as a potential solution for the future. And the end result is that when the billing is unclear, people are often motivated and less prohibited by law to get that put together. There's these things called GT modifiers. When I bill it, you get a 99203 and then you add a 0.95 at the end of the code. And then you've got that billing code for a telemedicine type encounter. So yeah, I wish there's an easy answer. I would echo the Center for Connected Health Policy as a place to look at sort of what the rules are. And then when it comes to billing, that's a question for the billing people. What I will say, what we do is we have, one of the great things about telemedicine is that essentially we eliminated charting. And people are like, how can you do that? Well, after a Zoom visit is done, you get a natural language transcription, which we send to a medical scribe located, I believe, in the Philippines. It then fills out the chart. The provider gets it within 24 hours and completes the chart. And then we send the chart off to a medical coder, also in the Philippines, who then appropriately codes. And I think our success rate with billing is in excess of 95% or something like that.
It is sort of a complicated area, especially for community health centers, because the policies just vary so widely. And I think sometimes there may be even confusion on the state level on what they want to allow. So there's another question here. I don't know, this is more of a general question. There should be an accountability check for the providers who prescribe opioids without owning the responsibility. What is being done by CMS and provider organizations for this kind of provider behavior, which is the root cause of the opioid crisis we are facing today? What are the proactive and reactive measures taken for this opioid addiction epidemic?
I wish there was a quick answer to this. I can keep you on the phone for another hour to talk about my thoughts, but the short of it is it's an all hands on deck. As far as accountability, often it's the state medical boards going after prescribers, which I'm not sure is the right way to do it. The way I think about it is 3 buckets of patients. The first bucket being the ones who are opioid naive, but are being considered opioids because they had surgery or they have a condition responsive to opioids. For this group, the CDC guidelines from 2016 applies completely. There's another group who suffers from the disease of addiction. They need treatment, and they need treatment, harm reduction, access to naloxone, information about where the services are that they need. And that's another group. And there's a large group in between who have been prescribed opioids chronically. And if we look at the latest research on that group, people are being forced to taper. And what we're finding is that forced involuntary tapers, which is different from voluntary tapers. If you have a patient who you talk to whom you're prescribing opioids to, and they say, hey, I'd like to cut down on this, it's really not helping that much, working with them is very successful. but involuntary tapers are leading to increased rates of emergency department visits, suicidal ideation, migration to more dangerous alternatives like heroin, as well as fentanyl that comes with it. So the short answer I would say is that it's all hands on deck. The federal government, to their credit, has been spending more money, almost $6.47 billion in the last couple of years on the opioid epidemic. But that pales by comparison because annual direct HIV spending is $23 billion. That's annually. And so the message that we need to send to our representatives is we need more resources in order to manage this problem. And I think telemedicine is one arm of it, but it's not the only arm.
I'm actually not sure if you can answer this next question, but it said, with commercial insurers, are you registered in every state and have a physical office location, or just Regus, or is there no need to register with commercials?
Usually they accept the Regis office where they can accept our mail. And we're talking to the national level plans, and they care less about the physical location than they do about the fact that we can provide those services. So the short of it is I don't think we have to have offices everywhere. And that's part of the reason as a company we can continue to run, because office space is expensive to maintain.
How do we inquire if telehealth or FQHC is legal in our state? It's not that it's illegal, it's just that will you get paid for the service that you provide? So depending on what payer you're looking at, if you're looking at Medicaid, you might want to inquire with the Medicaid office there to see if they will reimburse for the services that you provide via telehealth. If you're talking about a commercial payer, you would need to inquire with the plan. There's no state where it says it is illegal to use telehealth. It's a matter of like getting paid, and then also a matter about fighting like by those other laws such as licensing and prescribing laws and stuff.
Yes, that's correct.
Okay. For group therapy, is there a risk of privacy breach if someone walks into the room of one of the attendees and sees the other patients on the screen in the room?
Yeah, we have policies and procedures around that. The policies and procedures are that we say that it has to be private. You have to use headphones. And if we have any evidence that there's somebody else in the room, we give them one warning. And if that situation doesn't resolve, we cut off the line immediately. So it's something that's usual and customary. Hey, there's a chance that somebody could be looking that we don't know, but I think that's one of the inherent risks, and so that's part of the informed consent process right off the bat.
SMD 18-006 describes using MITA funding for MAT telehealth. Are you familiar with the funding to implement MAT telehealth?
I'm not familiar with that particular provision or where that comes from. I know that there's a lot of people providing funding opportunities, and a lot of this has to do with both the STR, the State Targeted Response Grant, the SOR, State Opioid Response, and the most recent Support Act. So a lot of it is federal funding that's going to the states, and then the states decide how to distribute it. For example, our company has, based on the STR and now SOR grant, we work with the drug courts in Ohio to sort of expand access. So there are, I suspect there are funding opportunities out there. We've certainly looked at a lot of them, and some of the funding opportunities, just because we're telemedicine, doesn't mean we can't go after standard grants to expand access.
Okay, some of these other questions that are here have been answered before, but this is the last question.
Okay.
Are you hiring nurse practitioners by chance?
Yes, and physicians and counselors and everybody. So, and again, this is not meant to be a sales pitch, but we're expanding services, and our goal is to get into all 50 states. So if people are interested in looking at extra income, let's talk.
And Dr. Khan did provide his email address, so you can reach out to him that way, or you can send us, and we'll be happy to forward it on to him. So that is it. These other questions were related to answers that you have provided previously. So I just wanted to take a moment to thank Dr. Haddad and definitely thank Dr. Khan for sticking around for a couple of minutes and providing this great talk today. To let everybody know, our next webinar will take place in August, and it'll be on mental and behavioral health. Also, very quickly, I would ask that, move on to the next slide, that you fill out this very brief survey regarding this webinar. That really helps us assess how we're doing and also help us with structuring the next webinar. And also because we are HRSA funded, they ask that we do these things as well. So if you can just take about 5 minutes and fill out the survey, we would really appreciate it. Thank you everyone for attending today. Again, thank you Dr. Haddad and Dr. Khan for your great presentations. And I hope everybody has a great weekend.
Thank you.
Thank you. Bye.